I want to know, of course, on the background of the scientific evidence against this background, what are the ideas behind when a new flap design is created? How does vascularity influence such new designs? Or I would like to know how suturing interferes with wound healing. Or regarding the grafts, I would like to know what really is the golden standard. How can we define a golden standard? If you look at this graft here, you can see this is harvested from a human patient. You see that there are 2 layers. And when we look at these 2 grafts, you can easily see, even a layperson could see, that these 2 compositions of the grafts are not at all the same, even if both have been harvested from the palate of patients. So the answers to these questions and many more will be the topic of these 90 minutes, and I can guarantee you that we will have an exciting session. So a principle in surgery means a basic rule that has to be applied, or maybe can be, preferably be applied. Omission of such a principle leads to an increased failure rate and maybe to more percentages of adverse effects. Now, to explain you the development of these principles, we have to look back 100 years. So at the beginning of the last century, clinicians like Wiedmann, Czesinski and Neumann, they published surgical approaches for the removal of the infected tissues. These people have precisely described their flaps. And the flaps were designed to get access to the roots and the bone. And most of these procedures were pretty invasive. Invasiveness did not change even if later on Kronfeld could show that the bone and the soft tissues were never infected. Nevertheless, more or less invasive surgeries have been published with the goal to reduce the pocket depth. And in the 50s, one started to mobilize flaps, first apically to reduce the pockets, later on laterally, as described by Gruppe Warren in the sliding flap. So this was the area when flap mobilization started in the articles with descriptions. Then with the increased awareness of the importance between the relationship of the mucosa, of the lining mucosa and the gingiva, a new domain in surgery was established, namely mucogingival surgery. And the intervention was the free gingival graft, which could be used for everything. While in the first half of the last century, most of the flaps were full thickness flaps, in the second half one started to split flaps, more sophisticated. And one of them was Wildermann, who described also the effects on the bone on for the resorption if we split the flap or not. So in this area, one started to talk about flap preparation. In the 70s then, Ramfjord described the Wiedmann flap, and one of the modifications was to avoid releasing incisions. We will talk about this later on. A lot of developments were published in the 80s. The free connective tissue grafts, implants have been established in private practices. One started to modify flap and also regenerative surgeries. This has changed dramatically the development because the era of biomaterial started. And biomaterial, of course, also influenced a lot our surgical techniques. Later on then, mucogingival surgery was replaced by plastic periodontal surgery, and also this dramatically influenced our flaps because now aesthetic was included in the definition and we were allowed to treat patients just on the indication of an aesthetic problem. So the patient was now involved in the development of the surgeries. Later on, the flaps were further modified regarding the access of the interdental area. I will come back to this. So today we can say that flap management was driven by the need of the patients, the abilities of the surgeons, and of biomaterials. There is something that all the surgical techniques, if we look at periodontal surgery at the beginning of the last century, or modern implant surgery, have in common. It's something that makes periodontal and peri-implant surgery more complex and different from most other surgeries in the oral cavity. It is the fact that the flap opposes an avascular hard non-shedding surface instead of a well-vascularized connective tissue wound bed. So this has influences on the healing. One aspect is the blood clot adherence, which is reduced on such a surface, and the second is the lack of a capillary network on these surfaces. Very early in the 90s, based on a series of studies, Wickersio and co-workers pointed out the importance of the early establishment of such a clot for the adherence of the flap. They could show that flaps have to be stabilized very well, otherwise the blood clot is impaired. They showed that the impaired blood clot, mechanically impaired or chemically, will lead to more recessions and to a further apical migration of the junctional epithelium. That this attachment of the flap is very delicate was recently investigated on behalf of the research group on oral soft tissue biology and wound healing. In 5.60 sites, recession type defects have been prepared, as you can see here on the right side, and the flaps in a control group have been resutured immediately after scaling the roots. After 1, 3, 7, and 14 days, the sutures have been removed, the incision lines retraced again, and the force was applied in the long axis of the tooth until the flaps detached from the root surface. The results have shown that within the first few days, just very, very low forces have to be applied to detach the flaps, less than 1 Newton. Then with increasing time, wound stability increased and ended at 6 Newton after 14 days. In comparison to the test groups, the interposition of a connective tissue graft or a collagen matrix firmly affixed to the wound bed could substantially increase wound stability. Another fact is the avascular surface of these wound beds. That means we as surgeons have to focus on potential sources for ingrowing vessels. The best source is the deepithelialized mucosa, splitted mucosa or elevated mucosa. Then we have also vessels penetrating through the cortical plate of the bone, and we have a very potent source from the ligament vessels. Keep in mind that the implant has no ligament. But it's obvious when we reposition a flap on a root, that means that the sides of the flap which are closer to the source of ingrowing vessels are faster revascularized than the portions that are far away. Such a wound in regenerative, angiogenesis research is called a nonlinear wound. Maybe a better example of this gradient of oxygen pressure is a free graft. That is the explanation why a free graft on a root surface, for example, for recession coverage, is not a very appropriate kind of treatment. So we come to the first principle. As a surgeon, if I do not want just blindly follow an opinion leader, I must be familiar with the basic knowledge in anatomy and vascularity. For the next principle, I come back to this graph again. You know, when GTR has been published, there was a huge enthusiasm in the periodontal community, soon followed by a big deal of frustration, because we could not duplicate these results in private practices. So the reason have been the materials, but one started driven by this fact to improve flap design. This was followed by the modification by the group of Cortellini and Tonetti, the modified flap, where the incision was placed on the buccal side, then the simplified flap, then surgical techniques like the single flap approach, or the avoidance of releasing incisions at all. When we do a regenerative surgery on a common basis, we use a membrane. And membrane requires space maintenance and also require primary closure. That means we have to elevate the flap for the primary closure. So we need 1 or 2 releasing incisions, which in turn also destabilizes the wound situation. The results that could be achieved based on a meta-analysis with a lot of patients included or sites is in a narrow angular defect with an infrabony component of at least 3 millimeters and at least 6 millimeter probing pocket depth, has in a non-smoking person with good hygiene 5 millimeters of clinical attachment gain. That could be achieved, compared to an axis flap with 1.7 and an enamel matrix derivative with only 3.1. Now, later on, these enamel matrix derivatives were published, the results, and suddenly we have 4.8, almost 5 millimeters of attachment gain. The materials did not change in between, but what has changed is the surgical approach. Because when a gel is applied, as you see here, we do not need a releasing incision. That means we have a much more stable wound, and this is the reason why the results have been better. So it's much easier to suture such a wound. And one could see later on, and this is also a proof, in a randomized study where they compared the surgical technique in self-containing defect with the enamel matrix derivative or combined with bone mineral, almost the same results could be achieved. That means that the surgical approach is essential, maybe more than the biomaterials. So, as a next principle, which was already described in the 80s in other fields of surgery, in this laparoscopic surgery, transferred into our field means that we have to reduce releasing incisions. That means to reduce the access. That means we should operate minimally invasive, which enhances wound stability. Do not mix this with the trauma. This means the access through the soft tissues. Another fact regarding the wound integrity relates to the interdental area. While in former times it was almost not possible to close a flap and to keep it primarily closed due to this only works in the drawings, later on the flaps have been modified to increase this primary closure or improve. In those flaps, none of the sides could be maintained closed in a period of 6 weeks. Also, most of these data are coming from the group of Cortellini and Donetti. So in a modified version, flaps could be maintained closed over the period of 6 weeks to 67% on a small basis of the papilla and to 73% on a wider base. And when these two procedures were microsurgically modified, one could achieve a closure of more than 90%. So this brings us to the next principle, namely, preserve the papilla whenever you want to get access to the interdental area. With this, you enhance the wound integrity and can maintain the closure. But sometimes, when we were talking now about these microsurgical approaches, then of course we need technical devices. And I can say today that it's a prerequisite that we use instruments with rounded hands, a basic set, and we use appropriate blades, and a set of elevators with very small working ends. Such a releasing incision, of course, can easily be done with a number 15 blade. You do not use a microsurgical blade, but when you want to get access to the interdental area, such kind of blades are to be preferred. The next part that belongs to this kind of trias is the suture material. The suture material should be fine, not only for reduction of the surgical trauma, it should also be fine because it could be shown in this study, in vitro study, that the breaking strength of a fine suture, a semino, is lower in many cases than the breaking strength of the tissues. That means with the selection of the right suture materials, you can control the tension that you bring to your flaps. So we need to handle these fine flaps and especially to handle in an appropriate way the delicate tissues, we need a magnification. And this was also a consensus of this workshop in 2013. We need a loop. So the last principle is we use round hand instruments that can define the rotated. Otherwise, tunnel techniques are not possible when you cannot finely rotate the instruments. Now we have these 4 principles. And of course, we can easily write them down on the screen. Now we try to transfer these principles into the clinical practice. So this, of course, will influence the outcome. We have the formal knowledge of the surgeon, we have the magnification aids, and we have the instruments. These all will positively affect the whole flap management. and a good flap management will positively affect the outcome. But maybe on a Monday morning, there are a lot of other factors. Your assistant is coming from the weekend, problems with a boyfriend, she's not at all concentrated. And now maybe you are a more sensitive character. That means that this fact immediately influences your tactile precision. And when your tactile precision decreases, maybe you cannot prefer the flap accordingly, and maybe you will have at the end a negative effect on the outcome. Another maybe situation, you had a meeting with your trustee, and he told you that your financial aspects, you spend too much money. So you think about if you use a 30 euro blade for the next patient, just for one interdental area. Okay, you decide to try it with a number 12 blade. That means, again, your flap might be squeezed in the interdental area, you cannot properly suture it, and you will have a negative impact on the patient at the end. I can go on. Maybe this Monday patient has a very delicate thin tissue. Again, the situation is much more complicated than with a thick mucosa. Or I can talk about stress. Psychological stress has been well shown to influence and impair wound healing. We do not know which patients really have stress. When we talk about biomaterials, I do not know, or I would say most of the biomaterials do not improve but interfere with wound healing. So I could go on. What I want to tell you is that you see that we are cooking a very complex menu. The problem is that we know most of these ingredients, but we do not know how they contribute to the final taste of the menu, or how the ingredients are interacting with each other. So what we would like to do in the next lecture is we would like to evaluate how the ingredients here of the site-specific aspects in the patient influence the whole flap management. And I'm very happy that today we have a 3-star Michelin chef here who can shed light on these questions. Dr. De Sanctis graduated from the University of Florence, and he did his postgraduate studies at Imperial at the Boston University. Today he has a private practice in Florence, embedded in a multidisciplinary team of specialists.